Hey everyone, chapter 12 is going to be the first chapter in our last unit of the textbook. So today we're going to talk about risk management, quality management, and utilization management. So in this book, the focus of health information professionals has been mostly on patient health information, but they also play an important role in risk, quality, and utilization management. So first we're going to talk about risk management, which is a non-clinical function. So non-clinical meaning it's not hands-on the patient. That has two main purposes. First is to identify areas of operational and financial risk or loss to the healthcare facility and its patients, visitors, employees. And then second is to implement measures to lessen the effects of unavoidable risks and losses. So to do so at the lowest cost and to try to prevent those things from happening again. So a risk management program is outcome oriented, which means they look at specific incidences to decide what could be avoided in the future and how can we do that. Now, I know we talked about charitable immunity a few chapters ago. That's when healthcare facilities could not be held liable for the negligent acts of their employees, okay? So when that went away in the 1960s, healthcare facilities started to have more and more lawsuits brought against them. So they had to start doing this risk management stuff. And on top of that, there was a medical malpractice crisis in the 1970s where people started realizing these malpractice lawsuits would cause higher insurance premiums. So Joint Commission started requiring hospitals to have risk management programs. And then state legislators did the same. Okay, so that's kind of the origin here. Risk management is going to look different from facility to facility. A bone and joint clinic is not going to have to worry about labor and delivery concerns, right? Also, risk management can be a part of a facility's safety department. It can be part of their finance department or operations, okay? It just depends. They can even report to in-house counsel. Now, the risk manager can be someone who has a background in law. They can be a nurse, health information professional, someone from the insurance field. Okay, regardless, the health information manager does play a role in at least two ways. So first is enforcing patient record requirements, and then through the use of incident reports. In terms of documentation, the health information professional really can't stress enough how important it is to properly document everything in order to reduce risk. Because remember, the health record serves as the legal record. It can prove what did or did not happen. It can make or break a doctor's defense in a lawsuit, okay? In order to be properly documented, it has to be both timely and complete, meaning all entries in the record are authored and authenticated and accurately show the care that actually happened to the patient. Okay. Now, to meet all the requirements for record content, which we talked about a few chapters ago, all the correct abbreviations, it needs to meet all the requirements for record content, like all the correct abbreviations, corrections or edits are made the right way, all those things that we talked about. Okay, security in terms of risk management typically refers to the availability of records for patient care, access to health information by patients, and the retention of health records. Okay, so all three of these topics we've already learned about, so you should be familiar with them. Also, the HIPAA security rule requires a risk analysis of electronically protected health information to determine what security risks there are in terms of breaches and to implement standards to reduce those risks and any vulnerabilities. So things like installing access and integrity controls on who's looking at patient health information, or making sure your staff is properly trained. The standards of the security rule actually don't specify the approach you have to take for this analysis, or like what security measures should be implemented. So there is some flexibility here, but they do require that this risk analysis is documented and maintained for 6 years. Oh, whoops, I was on the wrong slide. Sorry about that. Okay, as you would imagine, confidentiality is pretty important to reduce risk. As we all know, healthcare providers are obligated to keep patient information confidential, or else they can face lawsuits for violations of rights of privacy, breach of confidentiality, or breach of contract. Healthcare facilities can reduce the risk of a lawsuit like this by making sure doctors are educated on all the legal obligations to maintain that confidentiality, and just to make sure they're enforcing any policies that they have on this. Because it's not just good enough that your facility has a policy, right, if no one's following it. Okay, so you have to enforce it. Okay, so an incident report is the documentation of an adverse incident or hospital incident, which is when something happens that's not supposed to happen, like an injury or some sort of harm to a person, medication errors, slips or falls, loss of belongings, equipment malfunction, and the list goes on. Okay, there's so many examples of this. The report's going to describe the event itself, so that would include the date, the time, where it happened, okay, any and all details about it. It's going to have the condition of the subject. Was it a patient, an employee? Was it a visitor, or was it a piece of equipment? Okay, it will also include any statements or observations of witnesses, people that saw it happen with their own 2 eyes. And then any responsive action taken by the healthcare provider organization. So this is not part of the health record, which would just have, facts. The incident report can include subjective statements, so opinions on who is at fault. Okay, the incident report serves multiple purposes: to fully document the circumstances of the incident, and to identify situations that can lead to litigation. Okay, so the goal of these two things would be to loss prevention, right? And then also to create a database to monitor with the number and types of incidents, and to educate staff in order to prevent future incidents. These would be more along the lines of quality assurance, which is like changing the way they do things to prevent these incidents from happening again. Okay. So because the incident report that has all the details of everything that caused whatever the injury is, it's the most important source of information for whoever is bringing the lawsuit against the doctor. Okay, for example. In order to get the report, they would have to overcome any privileges. Okay, so quick refresher from one of the first chapters. Discovery, that's the process used by parties to obtain information related to the lawsuit. Admissibility is whether information can be entered into evidence at trial. And then privilege, the legal right to keep certain information confidential. So if there is a privilege, then they'd have to overcome that in order to bring it to trial. Now, whether an incident report will be protected by the attorney-client privilege depends on if the report was made for the benefit of the attorney alone, just for them to understand what happened, or if it was made for multiple sources, like the insurance company, the quality assurance department, okay, things like that. If other sources receive this report, then it will usually not be protected by attorney-client privilege. To help protect that privilege, the health information manager has to make sure the report is not put in the health record, because if If and when they request that patient's records, they don't want this to get sent with all of that unknowingly, right? Okay, risk management has improved over time with the focus now being more on automated databases. So using data in an automated way to try to measure the facility's risk. As you can imagine, it's a lot easier to just see some of these risk patterns or trends if you have an automated system that can spit out these reports versus looking through filing cabinets filed with all these incident reports that you have to sift through. Okay, so these automated databases can help predict with the probability of risks and try to help prevent any incidents from happening. Okay. Risk managers are also involved with making sure their facility is compliant with the Federal Safe Medical Device Act and with safety inspections from Joint Commission and any COBRA investigations. The risk manager also acts as a sort of liaison to the healthcare organization's attorney, which could include reviewing the records, arranging depositions, basically providing all the documentation for any claims investigations. Another effective risk management program is Sentinel Event Review, which is required by Joint Commission. Sentinel events is basically an unexpected event or occurrence involving death or serious injury, like loss of limb or limb function. Okay, examples of this would be surgery on the wrong patient or the wrong body part, infant abduction, major medication error, serious patient fall. Okay, so a Sentinel event is a major incident. Each facility is required to have mechanisms in place to identify, report, and manage these events. They're also required to conduct a root cause analysis to try to figure out how this happened, and any action plans that they developed because of it. Facilities are not required to report Sentinel events to Joint Commission, but they definitely encourage them to do so. Enterprise risk management is kind of a newer concept. It refers to all of the risk that could impact an organization, not just legal, financial, or medical, which is what is traditionally looked at. So this could include the threat of terrorism and how that would impact the community, the shortage of hospital staff, that people are more aware of medical and medication errors. It could be the state of the economy, social media influences, okay, things like that. So enterprise risk management looks at all these different types of risk and tries to figure out how they would affect the facility's strategic plan. In some cases, the risk could give them a competitive advantage, okay? Okay, that's it for risk management. Now we're going to move into quality management, or QM, which is another area that health information professionals play an important part of. QM does have some of the same databases as risk management. It's different in that where risk management is focused on the outcome to decide what activities to avoid, QM focuses on the process. It looks at patterns of activity to figure out what the best performance would be, like the best way to do these things. It's been called many different names in the past that you can see listed here. Performance improvement, continuous quality improvement, total quality management, quality control, quality review, problem detection. Okay. Peer review committees made up of healthcare professionals. They're used to evaluate, maintain, and monitor that quality of the services that the hospital provides. Make sure everything is up to snuff. So I actually did a role like this, or this role, for several months at Women's Hospital in Baton Rouge. And it was such an interesting process for me to review the patient records that had what we called never events, meaning they should never happen, and then presenting them to the doctors in the peer review committee, and getting to hear, their comments on everything. It was a really interesting role. Anyways, let's move on. Okay, in order for the peer review committee to be effective, they have to be comprised of neutral evaluators, provide feedback and recommendations, and enable candid criticism. So on these committees, the doctors are needed to really review and criticize the actions of their peers, which can be tough, right? They don't love to talk about what their colleagues are doing wrong. And some of them are hesitant because of the fear that what they say will be published and could lead to a lawsuit for like defamation, or that the doctor will stop sending them referrals or something like that. To address all of these fears, states have had to pass statutes to protect the records from the committee meetings from being accessed by other people, and also to protect the participants from any civil liability. Okay, so their peer review records are considered privileged, which means they are protected from subpoena, discovery, or being introduced into evidence, right? But it does vary from state to state. So not everyone is going to have these statutes. Excuse me. Okay. So what happens after the peer review committee, when it's found that a doctor did something wrong and they kind of, should have known better? Some facilities make the committee members decide what the disciplinary action they should take against the doctor is, whether it's, limiting their ability to practice in the facility, or even fire them altogether. Okay. To make these disciplinary decisions, they have to be very familiar with the Healthcare Quality Improvement Act of 1986, which was passed to make it so that this kind of information about a doctor's misconduct or incompetence is shared, so doctors can't move from facility to facility, just wreaking havoc. So this type of information is reported to the National Practitioner Data Bank. Misconduct can be reported by hospitals, medical societies, licensing boards, or entities involved in peer review, and includes any information about malpractice payments, licensure actions, and then adverse actions. So in that credentialing process, where a doctor, when a hospital's hiring a physician, the hospital is required to look into this data bank to make sure, to look at the doctor's history, make sure everything's up to par. And then they're also required to recheck it every 2 years. Okay. If they find anything in there, they can deny employment, or restrict or even terminate privileges if they're already employed. Okay, along with the data bank, Congress created a national healthcare fraud and abuse database called the Healthcare Integrity and Protection Data Bank, or HIPDB, which is part of HIPAA. That's where all the reports of final adverse actions that are taken against doctors, suppliers, or other practitioners if they're found liable of an adverse action. So this would be things like taking improper payments, performing medically unnecessary services, delays in diagnosis or treatment, and adverse outcomes. Only federal or state governmental agencies can access the HIPDB, although doctors, suppliers, and practitioners can search for themselves on it. There have been lawsuits against hospitals after firing a doctor for finding them in this data bank, but they're granted qualified immunity under the Healthcare Quality Improvement Act from being liable, meaning they can fire a doctor if they don't like something that they find in one of these data banks without worrying about the doctor suing them. Okay. All right. The last topic for today is utilization management, which is a combination of these functions: prudent use of resources and appropriate treatment management, and early discharge planning for continuity of care. Utilization review is the process of reviewing the patient's records to make sure their admission is appropriate, and to see what resources the doctor plans to use. This is usually started before admission and also looked at periodically while the patient is still in house to make sure the care is necessary for the patient. Because if it's not, the health insurance, the insurance company, the payer, is not going to pay them for it. Okay, so these people are to make sure that the patient is getting only what they need. All right. There's actually a good table in your book in this chapter that goes over the differences between quality, risk, and utilization management that I highly recommend you looking at, because they can kind of seem to overlap a little bit. So check that out if you want kind of more distinctions on the differences. Okay, so utilization management efforts began in the 1950s because there were a lot of bed shortages. So they would see who had the greatest need and allocate the beds that way. It didn't become mandatory until 1965 with the passage of the federal law that established the Medicare program. At first, they were focused on reducing the patient's length of stay to cut costs. They also required medical reviews to try to improve the quality of care. And then in the 1970s, several things happened. So Joint Commission began requiring utilization management. A new law was passed that led to the formation of the Professional Standards Review Organizations that monitored quality outcomes. And that was in 1972, I believe. In 1977, the Utilization Review Act was passed, which required doctors to do constituted stay reviews to check for medical necessity. And then last, the Healthcare Financing Administration, which is now Centers for Medicare and Medicaid, opened to manage the Medicare and Medicaid programs. Okay. Then we have the Tax Equity and Fiscal Responsibility Act in 1982. This stabilized the Medicare prospective payment system and really just changed reimbursement in a big way from being per diem or per day payment to a predetermined amount based on the patient's diagnosis. Okay. By the 1990s, the process of determining medical necessity moves past just Medicare and Medicaid. Then all insurance companies were looking at it and only paying if a patient was pre-certified or pre-approved. Now we have what's called quality improvement organizations, which uses evidence-based guidelines when reviewing records. And so lots of changes over the years, okay? Case management is the ongoing review of patient care in different settings. So hospitals, long-term care facilities, home health, okay, to ensure that medical necessity and that the level of care is appropriate. Case managers or utilization coordinators are who manage this review process. These are typically nurses, but HIM professionals can do it as well. And then also some social workers can help out here. All facilities have to have a utilization management plan in place that's going to say like how this process works. Okay. The first step in this process is the pre-admission and admission review. They're going to confirm the patient's insurance company and make sure they're approved to have this procedure or to be admitted. Okay, they want to make sure we're going to get paid if we do this for this patient. Then while the patient is still in the hospital, we have concurrent review to make sure there's still that medical necessity and that the patient is getting the appropriate care. Also that all of this is being properly documented, okay, in case the insurance company has any questions. And then we have discharge planning, which involves coordinating all the things that need to happen for the patient to be released from the hospital. And then, all at the same time, case managers will work with the health information manager to conduct audits and reviews to make sure they're compliant with everything. Okay. And that is all I have for you today. Let me know if y'all have any questions. Goodbye.